My name is Sarah Kusler. I am the events manager for Experience Tulsa, and this is our third Parent Talks event with TulsaKids magazine. We are super excited about this collaboration with them to be able to bring you these lunch and learns. So I'm going to go ahead and kick it over to Betty Casey from Tulsa Kids Magazine to give us our introduction, and I'll keep letting people in this room.
I'm going to briefly start my video. I'd like to welcome everybody. Again, I am editor of TulsaKids Magazine, and I appreciate everyone coming to our Parent Talks. I want to introduce Dr. Daniel Nelson, MD. He is the former medical director for the Child Psychiatry Unit at Cincinnati Children's Hospital Medical Center. And Cincinnati Children's is the largest provider of inpatient mental health care for children and adolescents in the United States. Dan enjoys working with children who have unique challenges. He's a founding and advisory board member of the National Center for School Crisis and Bereavement, and has traveled to disaster and crisis areas. He's helped children and families cope after the September 11th attacks in New York City and after the Oklahoma City bombing. He has extensive experience in neurodevelopmental disorders, and Dan and I have known each other since third grade. Welcome, Dr. Nelson.
Thank you so much for the kind introduction, and I welcome everyone. It's a joy to be with you all today. I'm actually at the national meeting for child psychiatry, and the workshop that I just slipped out of to do this, we were discussing a lot of the same information that I saw some of the questions from the group. I might first lead with, I'm a pretty informal kind of person. I train a lot of medical students and residents in psychiatry and child psychiatry. And one of the things I emphasize that I love about being a child psychiatrist is if we run out of chairs in the room, I just sit on the floor, and I want people to know they can interrupt me at any moment. And I believe that I learn as much from the children and their parents as I can offer to them. So I think it's a reciprocal learning. But to really show you, I mean, that I'm an informal kind of guy, I'll sing you Upside Down Town. In Upside Down Town, the sky is on the ground, and the ground is where the sky should be. The rain is falling up instead of falling down, down in Upside Down Town. That's the first verse. So I think Betty and I, we have a lovely time chatting, and it was from our little banter that we thought this would maybe be a helpful thing. She's gotten a lot of questions, particularly about ADHD and the challenges that those children and families have, as well as autism. But I do treat a full spectrum of psychiatric illness in children, and I also specialize in addiction and families challenged by addiction, which is how I think about it. But wherever you guys want to go, and I think Betty might help me out with voicing the questions, but also kind of being a moderator. Keep me on task.
I do, to interrupt just briefly, I did place in the chat, someone asked about how to find an advocate for IEPs locally and some other types of support groups. So I did put those in the chat with links. And so I just wanted to point that out to everyone. And, you know, we kind of have started with people have asked about early signs of neurodiversity in young children, what those might look like, and then some practical tips for working with kids with ADHD and at home and possibly at school.
Yeah, so we could start wherever you'd like. Is there a particular place? I will say this, Betty, and I so appreciate you gathering that information. What I tell families when I meet with them about IEPs is there's a formalized process. It's from a federal law, 94-142, which is the American Disabilities Act. And parents have the right to go to the school and request an evaluation of their child. I recommend people do that in writing with 2 copies. When you hand it to the person, make sure you write down their name, the date, and the time. Have them sign 1 copy, you have 1 copy, because it starts a process that's 90 days long, and that's their evaluation time. And then there should be an IEP. If the child's qualified for an IEP, after those 90 days, it should happen. That's federal regulations. If you are having challenges with a school, and it's understandably to me that the schools sometimes are slow on this because we don't always do everything we can do as taxpayers to fund them well enough, and children with these special challenges often are more expensive than other children by a factor of, probably even 5 to 10. So they sometimes drag their feet. But if you get an educational advocate, which is usually a person with a law degree they can come in and help with that so that the school follows the law. You'll also be offered something called a 504, which can be very helpful. But the way the law is written, a 504 is a handshake and an IEP is a contract. So if the IEP says your child needs these services, like a Velcro aid, which is a person who would sit with your child, one person sitting right with your kid to help them with all their school, that would be a high intensity intervention. If it's a 504, they don't have to provide it and they can take it on and off. But with an IEP, it has to be there. They have to follow the law. So the resources, I'm sure, are very helpful, but I like to orient parents to what their rights are. Where would you like to go next, Betty?
I'm like, maybe starting with some of the signs of neurodiversity in young children. We had a couple of questions about that.
Yeah, and I've thought about this a lot since we've started working on the talk here. And if it used to be in the beginning, back in the mid 40s, there were two people. One was in Europe. His name was Asperger's, and the other was at Baltimore, Maryland, at the Johns Hopkins Hospital. They both came up with this term autism. And it turned out that Asperger was describing a variation of it that's much brighter, much more social and interacting typically than children with autism. But we've moved to a notion of a spectrum of disorders. So those two diagnoses have kind of, in our diagnostic manual, have gone away, and we now have autistic spectrum disorder. So when I work with families, I try to help us learn together just where is the child on the spectrum, because many of the patients I've worked with, some of whom have reached adulthood, because I've done a lot of work with individuals throughout their lifespan with autism, they can be so affected by the autism that they don't hardly have any verbal language. And they may have a lot of what are called stereopathies, where they maybe flap or spin. And it can be extraordinarily challenging just to get them to learn to eat or do activities of daily living, like, getting dressed and so forth. On the other end of the spectrum, it can be very, very, like, it takes a trained eye to see somebody with the really subtle forms of what we used to call Asperger's, because for them, it may be just a little bit hard to tell what other people are thinking or even to articulate their own feelings. And so they can get into some complex social situations where they just, I like the words of Temple Grandin, and I don't know if you have a child with autism, I highly recommend. Temple Grandin has written a number of books. She has autism. She's really guided us to a deeper understanding of autism. But one of the things that she said in a YouTube video I watched, and she's very articulate and she's very bright, as are 25% of the people with autism, they can have a superior IQ. So a lot of assumptions people make about autism, they really don't apply to given individual. But one of the things she said is, if I go to a drama movie, it's like watching people interact about social or romance is like if one of us went to watch a movie in Japanese. It doesn't go in my brain. She says, I have to calculate what another person might be feeling by kind of a checklist. And now she happens to be a specialist in animal husbandry. She went to Colorado State University in Fort Collins and got her PhD. And she said, I can watch movies of animals in Africa like eating each other completely. That most people would just go, it's terrible. But she goes, I can watch that. And it doesn't affect me emotionally because I just think, well, that's natural. I'm seeing something natural. Whereas, I see another animal getting eaten and I start thinking about what would it be like if I was eaten, and I feel a certain amount of. So the filters are different, and the things that can trigger children with autism are different. So another example that Temple gave is if she's in a room with a ceiling fan, just having that thing go round and round makes her brain just feel like, something terrible is about to happen. So there's certain triggers. And I'll give you a for instance with one of the patients I had is this child would come out of their room, quietly go to the breakfast table, usually sit down and eat. And one morning, the child came out and just started screaming uncontrollably, and nobody knew what was wrong. And they ran to the child, and they were trying to like, "What? Tell us what's upsetting you." And they weren't very verbal, so they just kept screaming and were very activated. And what they discovered is one of the parents had moved the ottoman from one place in the room to the other place in the room, and that wasn't where it was supposed to be in that child's mind. Just made them feel horrible. Now, when I think about, well, how would that happen to me? If you can imagine waking up and getting up in a house that you've never been in before, thinking you went to bed in your own home, and you got up and you started looking around thinking, what is going on here? I think I could experience a similar, maybe not the same, but a similar level of distress that child had in seeing that the ottoman had been moved, because it just triggered that, like, something's absolutely wrong here. And I think it's very helpful. This is what I love about Temple Grandin, is she invites us into better understanding of what it's like to have a different orientation to the world that in some ways is actually unique and very valuable. Most of the families I know, once they really understand their autistic family member, they start to learn things that they would never have understood without it. And they say, my life is different for having had this very special relationship.
That the reaction of the child that you described, we had several questions about what the parents called meltdowns and how to prevent those. Can you talk a little bit about that?
Yes, I can. And the meltdowns are they're really difficult, not just for the child who can be in extreme distress, but I think meltdowns are a challenge for the whole family, because they're so intense as to be disruptive of everything else. If other children are in a home, having somebody screaming or maybe hitting themselves or throwing things, they can become very aggressive toward themselves, toward other people. Um, so part of it is learning the special language that each child has, or what their triggers are. There are things that can help calm children, even having sometimes a weighted vest, or having things arranged a certain way. Many children with autism um, they can be hypersensitive to like how clothes feel. I can't tell you how many children I've seen that wear their shirts inside out, because inside out you don't have the seam of the sewing up against you on the sleeves, and you don't have the tag. Um, Many children I've worked with will just lock into a movie. Like, it's interesting to watch. Here's a kid who, if you don't do anything else, they will watch the exact same movie 80 times a day, depending on how long it is. Um, or Minecraft. There's certain video games, if they get a hold of that, man, I can't tell you how many children I've had hospitalized when the family felt like we can't do this all day every day, and they take something away that in an interactive way for them, they're so positively connected to this, they feel severe distress when you take away this thing that they. Now, I've also seen that in typical adolescents, it can be like that about their cell phones. If you have to take a cell phone away from a teenager, just be ready. Because they can go into they can become suicidally depressed. That's why they get hospitalized. So there's all that nuance of understanding that person's way of looking at the world and what their triggers are. This workshop I was just in, I was talking to actually a panel of really four of the leading experts in the country on psychopharmacology and using medications, and autism came up several times. So it was really lovely for me. They knew the current scientific literature really well, and I was like really. One person was just a commentator. The other three were editors and people from Stanford, but two of the three people in the panel I had trained, so I was really proud that they were up there talking. One of the things that families can really be interested in is, what about using medication to help with highly aggressive behavior or disruptive behavior? Or we talked about actually ADHD in autism, and a number of things that we've learned, I think, are quite helpful. In the course of my 35 years as a child psychiatrist, um, one of the big concerns we've all had, and I know parents have this too, is if we're getting medication, you know, could that medicine hurt the child? Could it cause a problem with their vital organs? Could it somehow damage the brain? And so over the last 35 years, there's been a lot of scientific inquiry into that, looking closely at medicines and what potentially can happen. And what is becoming more and more clear with almost all the medicines is that if the medicines are effective and they reduce the symptoms, they reduce the distress, the aggression, depression, anxiety. As that continues, what we realize is that the illness itself, the more times it happens, the more it actually damages the brain. So to be very specific, the more times I might have a depressive episode, it's like I'm cutting a groove deeper and deeper into a rut or a skip on a record. Or even if I just sit down and play at the piano every day, the more time I spend at the piano, the better I'm going to be at it. So the more time you spend doing depression or doing anxiety, it primes the neurochemistry of the brain, and it's going to create a higher degree of symptoms from that illness. So what we found is that when we give medicines and they work and they reduce symptoms, um, the brain, we can now measure the brain using scans such as an MRI or functional MRI, and the brain actually ends up structurally more healthy. And another thing that I thought was interesting is the symptoms of ADHD. There's there's the inattention and hyperactivity and disruptive stuff. But we've also learned that the children who have ADHD, especially those who don't get treated early, there's a lot of other what we call sequela, additional things that happen. The child's self-esteem begins to be eroded because often they're identified as the problem child in the classroom, and people make comments that are sometimes devaluing or unappreciative of what the child's challenges are. They actually have a higher risk of motor vehicle accidents. And ADHD diagnosis puts you at higher risk for substance use disorders. Um, and what they were absolutely clear about, because there's been a history of good research, but there's a lot of current research that just came out. The longer a child is on ADHD medication, the less those things happen. The less the self-esteem ends up better. The average American has about a 15% chance of abusing drugs. Children with ADHD, it's almost 30%. Children who are getting ADHD medicine, and these are often stimulants, that number doesn't go up, it goes down. It goes down to 15%. So it's the same as an average person. Because the early concern was, well, if we're giving a child stimulants, are we going to put them at risk for using things like methamphetamine or cocaine or whatever? There was even a time not too long ago we were like, what about the opiate epidemic? Are ADHD kids more likely to use opiates if we give them a controlled substance when they're young? And thankfully, at least I'm reassured by this, the scientific evidence is really strong. No, it's protective. To get treatment, the more successful the treatment and the longer they're on it, the more protected they are.
That is so interesting. And so a parent would need to visit with the child's pediatrician, who would then help them find maybe a psychiatrist or someone else. And before you go, there's a question about medication, and this is, you might personally have relate to this. Is there any medication that could benefit an 8-year-old with dyslexia?
Well, that's a question that's near and dear to my heart. In my introduction, Ms. Casey didn't mention, and which would be fine, probably. But I grew up with dyslexia. I still have dyslexia. It still haunts me. I end up talking to lots of kids with dyslexia because often the parents feel like, hey, if you got through medical school and residency, you must have figured something out. And I was really lucky. The elementary school that Betty and I went to, dyslexia had just been identified as a challenge for children, and somebody from Oklahoma State University came to our school, looked through the kids' records, and actually kind of plucked me out of my classroom to help me learn to do a lot of remedial work. I went to school early in the morning and I stayed late to work with specialists who were trying to help me learn to read. And in fifth grade, I couldn't even read at all. I was still like, you guys maybe don't remember this, but it was Dick, Jane, and Spot and Puff. So I was still working on that in fifth grade, which was a kindergarten level of reading. And in that year, because I got this help, my reading went from kindergarten to almost the end of fifth grade. So it was a big catch up for me, which was, I'm sure, very helpful. Um, the medications that we know of, as far as I can tell, I haven't looked at this in a number of months, but as far as I know, there's not a specific medication for dyslexia. But in the way I was talking about kind of that self-esteem or emotional erosion, when kids have special challenges, they feel different, and lots of kids wish they just were like everybody else and liked everybody else. We don't always enjoy feeling different. And so if you have one challenge in your life, the possibility that you're going to have additional challenges starts to go up. So, a lot of my work is with what we call comorbidities. So, um, if you have autism, it's likely you may be challenged by more than just autism. One of the things I was talking to another child psychiatrist about is I look very closely at the family history, because mental brain health is what I like to call it. Brain health is often runs in families. We're genetically vulnerable based on the genes that we inherit, and illnesses run in families. You'll often see it. I've had families that have 3 autistic children, and talk about a handful for the parents. One of the things when I was reading you guys' questions, and I'm just reminded by the way you guys are asking your questions and that you're on the phone. You know, really good parenting is this quest to try to find what helps your kid. And I don't think people often find it in one place. It's like a lifelong learning thing. And so you often have to go to lots of different people. And this is one of the reasons I like learning from my patients and the families, is they teach me things about what they've done with their kids. And then I sometimes will say, well, here's a family that tried this. So the comorbidity with dyslexia could have an impact on the child that has to do with, self-esteem, which psychotherapy can be very helpful for, anxiety, depression, um, other learning challenges, because this dyslexia is just one learning disability, and there can also be challenges with communication or calculations and such. So it's good to dig in deep. But usually medication would be about treating a comorbidity, an additional illness to just the dyslexia.
This is about dyslexia too, but if the intervention, if the child is not failing enough to spur intervention from the school, do you recommend for pushing for independent testing? And I would say that's true of anything. If you suspect anything, but it's not enough
Yeah.
to go through the school, or the school is not providing that, do you wait and see? Do you do independent testing? What would you recommend?
Well, for me at least, knowledge is often where our strength is. And so learning more about what is going on, learning more about the resources that one might use. And sometimes there's going to be resources that you might be able to access in the school, like we were talking through an IEP or a 504. But if the school can't provide it, sometimes if it's available, it can be great. And this is one of the nice things about, you know, the new virtual world that we live in. Is it used to be, I would talk to people in rural Oklahoma or rural Ohio or Kentucky or Indiana. Those are the places I practiced the most. And they didn't have access to resources. And it was just like, you're cut off. But now you can access people all around the country, in terms of talking to experts. So that can be very helpful if you can find out who is available. They don't necessarily have to live nearby for you to be able to talk to them and maybe interview your child or try to address your concerns and give you ideas.
Right. I want to go back to, because we do have a lot of questions that are sort of just basic how to. I like when we talked before, you talked about not letting the kid drive the bus. But, and this is true, I serve for just neurotypical kids, but neurodiverse kids may need a different method of how
Yeah.
parents do that. But can you talk a little bit about, like, if you talked about a kid on screens all day and the difficulty, how engaging that is in getting them off, or getting them to get dressed for school or do those things they do not want to do. How do you deal with a neurodiverse child in those situations?
Well, I'm gonna uh, I'm gonna tell you what I think is the secret in life, and that is, as much as we might want to be able to change another human being, I don't think we actually have the power to change anyone except ourselves. And how we change ourselves certainly can change the way other people see us or behave with when they're with us. So, one of the things that I have found where I've seen dramatic changes in families is if in our parenting, I know when I was being parented, my parents were probably like most parents, and they had a sense of, wanting to give and nurture and be sure we had what we had. But when we started to color outside the lines, there was a strictness and a wish to control things. And part of the way that they used I have two sisters, to parent us was to show us their displeasure when we weren't doing what we often needed to do. I mean, this was part of them, teaching us good social skills. It's not that they were being mean or harsh, but I have found, both with my own two children and also the children I work with, if there's a way to approach what you're doing with your child that you enjoy what you're doing and you kind of even make a game out of it, um, it's a lot easier to get away from feeling like you're, hitting heads or you're stuck. Um, I was with my granddaughter, who's 2.5, last night and didn't want to go to the bathroom. And for whatever reason, she invited me to go in the bathroom with her to help her on the potty chair. But she'd already been, like, we were in a restaurant here in Chicago, and she's like screaming her little head off. And so when we went in, there's a song we've been singing for her toilet training. And I just looked at her and I said, "Do you like me to sing the song?" It's a song I wrote. And she just looked at me and, kind of like, and without answering the question, I just jumped into, pee pee in the potty chair, pee pee in the potty chair. And so, one of the ways in which our minds work, um, I'm going to say this is almost certainly true. I'm going to say something, and I don't think you're going to be thinking about it or imagining or seeing it in your mind's eye until I say it. But I'm actually going to ask you, do not think about purple elephants. What are you guys thinking about? You have to think about purple elephants in order to not think about purple elephants. And when I was an undergrad, I was a preschool teacher. That was my undergraduate education. And I was helping a 3-year-old who was on a tire swing kind of thing, or a rope swing. And just as she got ready it was really low to the ground, but just as she started to swing, I said, "Don't let go." Well, that doesn't exist. And she let go and she slammed into the sand that was beneath this and started to cry. And I picked her up, and I realized what I'd done is I planted a negative suggestion. So when you say, "Don't do this," you've actually brought up the topic. So don't be afraid. Or I talk to doctors, like, when you walk up to a kid with a shot and you say, "This isn't going to hurt," they now know three things. One, they're thinking about it hurting and they probably believe it will, and they suspect you're a liar. Whereas if you go up, and I love curiosity, I love the neurochemistry of curiosity. So often in that situation, what I'll recommend is to people is like, have you ever had a shot that was fun or felt okay? Now, I'm introducing the idea that there will be a shot, but it's a different experience. And so in doing that, the child then begins to think about things differently. So if I'm in a situation where I'm stuck with a kid, um, I'll give you another instance, and this was with my son because we would go to the store, and I didn't. One of the things I set up because I watched a lot of kids throw temper tantrums in the stores, so I just kind of came up with a rule: we're not going to buy toys at the store unless we say that's why we're going. So if we're going to go buy groceries or this and that, I'll make it really clear before we ever leave the house: we're not going to buy any toys. Well, all the television commercials are set up to affect the psychology of children to be demanding about being consumers. So of course, my son, who at the time was probably 4 or 5, he was going to throw a big tantrum because he saw something he wanted. And right away, I thought, well, this is great. This is an opportunity. So rather than seeing his temper tantrum as him doing something he shouldn't be doing, I said, look, you're wanting to show people how you do your temper tantrum. This is great. Um, let's look around and see who's watching. Maybe can I invite them over to see how good you are at the temper tantrum? And so I'm not talking about no, you can't have a toy, which would be to continue to engage in conflict. I just go, oh no, we already said we're not going to have any toys, but you're showing me a good temper tantrum. Let's go out in front of the store, and you can show the people walking in your temper tantrum. And then he starts going, I don't want to have a temper tantrum. And I'm going, are you sure? You're really good at it, you know. But the way to reinforce the temper tantrum is to kind of say no, 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 yes. It's what's called intermittent, unpredictable reward. And this is why, if you want to kind of like fundamentals of parenting, one of the best ways to help kids really deal with the world is to be consistent and predictable and supportive. So if you know, say what you mean, do what you say, that really helps them to understand this is the way things are. And they're going to test you. I've never met a child who didn't test limits. Um, Before I went to medical school, I was a teacher in the public schools, and I did a lot of substitute teaching. And man, I don't know if you guys remember, but when the substitute teacher walked in the room, I was the one testing the limits with the substitute teacher. Um, and so I went to the best teacher I'd ever had and asked her about how to cope with that. And she just said, always be prepared and let them know this is the schedule, this is what we're going to do, make it predictable. So for instance, in the children who come into the hospital with autism, they're away from home, everything's changed, it can be very, very challenging for them. So what we do is we give them a visual schedule, and we make each event in the day is kind of got a little Velcro thing, and we put what time and what they're, here's when you're going to eat, here's when we're going to do this group, here's when you're going to get dressed, here's when you shower, here's when your parents are going to, and just, they begin to get anxious. But we go over and we look at this, it's almost like a poster, and we can say, oh, here's what's coming next, and then you can offer, sometimes it's nice to be able to offer children the choices that they can do. And so for instance, there's even something called the illusion of choice. So would you rather brush your teeth before or after you put on your pajamas? And for the child who's kind of a bit oppositional, it's like, oh, I get a choice, I can do. But the suggestion is actually, you're going to brush your teeth and you're going to put on your PJs. So those kinds of things can be helpful. But I will tell you, there's not been a child I've always met children who could sabotage one or another approaches. It's like you have to have a menu and a catalog of things you could do. But as long as you're having fun, and if I get in a difficult place, you can kind of get, stuck and, it's good to take a break if you get to the end of your rope, which happens and happens with children with challenges. One of the things I'll ask parents um, during an interview after we kind of get to know each other a little bit is like, well, do you ever feel like drop kicking your kid? And I don't ask that because I believe they want to hurt their kids. I ask that because I believe most parents, if not all of us, at some point, just want to pull out our hair, whether we have it or not. And that's just a natural part of parenting, as far as I'm concerned. But to make it safe for us to talk about that anger and frustration in a session, so that they know they're not alone and they're doing really good parenting. And so when I looked at you guys' questions, to get back to the earlier point, I just saw such good parenting in that, like, I want to know and understand my child and what they're challenged by, and I want to learn, what I can do. So obviously, we talked about medication, but there's also, psychotherapy and parent coaching and a support network. And, with the families that have autism, I can't tell you how many parents I've worked with. Their child's like 18. And one of the fun questions I like to ask was to the parents, hey, when was the last time you guys went on a date? And I can tell you, maybe 2/3 of that particular parent group will go, before we had kids, because there's not anyone that's willing to watch their kids that they feel has the skill set to tolerate the challenges that their child has. And yet, I will also tell you, one of the challenges for parents with these children who have these challenges is not just their family or the community or, being in the store. People look at you like, why don't you make that child behave? What's, they act like you're not doing a good job as a parent. And I know parents just want to go, hey, you take them for 2 weeks and let's talk. If you think you can fix this just by parenting, because usually I think most people, they figure out the parenting answers pretty quickly, what's going to work and what doesn't work. So there's a lot of the kids I see that I don't, at least I don't think I have the parenting skills to fix the problem that the child has, the challenges. It takes multi-system intervention, because some of this stuff is really brain neurochemistry. So I wouldn't expect parenting to be able to take a child who's in a wheelchair and have them get up and run laps. Like, no amount of parenting is going to do that. No amount of parenting is going to keep a kid from having an asthma attack or cure their cancer. You have to know, as my job as the parent is to help them get the supports that they need that don't come within the family. And so many parents I work with they're kind of beat up and discouraged because so many people are critical of them. And I tell them, look, in my book, you're an angel, because I think your day-to-day life is full of challenges and frustrations, and you've got a child who knows they're loved and loves you, and I can see they're well dressed and well fed, and you're here getting them help. So I wanted to take a minute to praise you guys for what you do for your children.
Oh, you are so sweet. um, I love you, Dan. Okay, here's another question. My 10-year-old hits himself constantly unless wearing arm braces. Any advice on how to transition to times without them, like bath and bedtimes?
So this parent is being really generous, kind of showing us just how challenging things are with her child. And um, if you all don't understand or are not familiar with it, these arm bracelets, they kind of lace up like a shoe would, but they keep your elbows extended, because if you don't stop this behavior, they will hit themselves so many times in the head that it's not uncommon for them to get like a retinal detachment and go blind. And we've had patients who have been challenged in that way. There's also special helmets that you can get for the kids. So again, there's probably a whole, I don't often, it's not often I can pull out the silver bullet that'll be the answer. But to go thematically to what I was talking about, um, I would I would say, well, hey, let's start with what is it your child, I'll just say Johnny or Susie, what is it that Johnny or Susie loves to do that if it was there in that setting, maybe it's a certain toy, an activity, it could be a video, I don't know, what it could be a type of food. What is it that they would be so interested in that if we got it there when the braces came off, that they would be so riveted to that we would hope that they have less of an impulse to hit themselves. Now, I would also say sit really close and catch that arm before they hurt themselves, because you want to have what we call proximity. You want to be right close when you begin to do this. But when you're transitioning from this real kind of rigid self-injurious behavior, um, what you want to do is find that little key and then begin to find more and more things that you can then expand on to stretch that time out more and more. Now, we've treated a lot of self-injurious behavior, and there's kind of a pretty good array of medications that do help with self-injurious behavior. One of the things that we wonder about is that the reason that opiates work is that almost all those molecules that make up opiates are derived from morphine, or a compound that's really similar to morphine. And the reason that works is that our brain actually has receptors for those types of compounds because we make them. Our bodies make natural painkillers called endorphins and enkephalins, and they work just like morphine. So um, if a person gets into a really distressful situation, they can stop their own pain. Like if the house catches on fire and you might even be burned, but you would run out of the house before you'd even know you're hurt. Or I know Betty's a runner. A lot of people can run and they're hurting and they're hurting, and then they hit this wall, or not wall, but they get their second wind, and suddenly the pain just goes away. And that's what's happened, is there's been a massive release of these natural compounds that kill pain. So one of the concerns we have about these children who are hurting themselves is that they actually don't feel their pain like most people would. So there's a medication that's actually used to treat people with addiction called naltrexone, and it blocks those receptors so that they can't the endorphins and enkephalins can't kill the pain. And so for some children, that can really be helpful. Now, I will also tell you, almost all my experience with children with autism and psychopharmacology is it's an adventure. A good way to put it. It's an adventure to find first what works, and then it's an adventure to find something new when something stops, and try to know when to go back. And it's a long path. Autism, especially, is a marathon. It's not a race. There's not quick and easy answers. There's a whole process of learning how to support the child emotionally, behaviorally, psychopharmacologically, finding people you trust who will listen. I can't tell you how many doctors I've worked with. The biggest problem is they're not listening to the patients or the parents. Um, you really want somebody who can stop and listen and understand your situation before they start trying to design interventions. And once you find that person, it's like finding the really good partner in life, or a good mechanic, or dentist, or the people we trust to really help us. If you find that person, the other thing I grew up with, other than dyslexia, is hemophilia. And I spent a lot of time at Children's Hospital in Oklahoma City, where I later went back to train. And I had this fabulous doctor. His name was Daniel Lane. And he taught me about hemophilia is a bleeding disorder. So when I got hurt, I would just keep bleeding. And one of the things that he said to me has really helped me a great deal in my own personal life, but it's also helped in patients, is he says, you need to be responsible for your illness. You're the person who can determine what kind of activities you do, or if you get hurt, how quickly you stop and treat your bleeding so it doesn't turn into a big problem. And so that's how I think about these long-term kind of chronic illnesses, is that it's a quest to find what can work for a given situation. And it sometimes involves trial and error. Another thing it's probably worth noting about medications is um, one way to approach medicines is, I call it linear, where you have a target symptom like anxiety or ADHD, and you give a medicine and it addresses that target symptom. And ADHD is actually one of the things that medication works for ADHD better than it does any other illness, not just psychiatric illness or behavioral or brain illness, any illness, period. And the reason that is that placebos work 5% of the time with ADHD. Placebos work with cancer 20% of the time, 25% of the time. So it is really non-responsive to a sugar pill that doesn't have any activity. But when you give it, about 75 to 80% of the time, stimulants can help. So they have a real quick, profound effect. But most of the kids we're kind of talking about, the straightforward ADHD kid, they mostly get treated by their pediatricians and things get better and life gets back on track. But the complex kids that I typically see, um, it's a lot more like baking a cake. So I can get, if I'm trying to treat, depression and PTSD and ADHD and anxiety, I need to find the right balance of medications that kind of work together and don't, kind of maybe hopefully cancel each other's side effects out so they're well tolerated. And there are good medications, but, you know, I can have everything right in the cake, right? And if I forget the salt or I give 3 times too much salt, everything else is going to be bad, right? It's just going to be a bad cake. And that is often the complexity of psychopharmacology, is that you sometimes can't tell if it's one thing that's the problem. You kind of have to get everything in the right proportion together, treating each element of a complex situation. The easy ones are usually resolved with one medicine, but that's not the case. I see the complex kids.
Um, how would somebody find? Is it difficult to find help? I just listening to you, I think some of the complications and the comorbidities and all of those things, the pharmacology involved in all of that. My question is like, how do you find somebody that knows what they're doing?
That is a great question, and I will say too that um, I see a trend in medicine that concerns me, and that a lot of physicians in their training, they kind of are shifting to, I only do this, this and nothing else. Like, I'll give you an example. My mom, who's next month turning 92, about 10 years ago, she went to the doctor and she had a UTI or something. And so they sat down, they wrote a prescription. And as they were telling her to go, she says, "Well, I'm also having some difficulty breathing." And they said, "No, no, no. One problem per visit. You'll need to leave and come back with your breathing problem." And, I just was like, "No, please tell me this isn't true." Because I really think the physicians who are providing the best care, and I'm also going to include nurse care managers, because there's, for one, child psychiatry is in the highest demand of all medical professions. We have the biggest shortage in child psychiatry. It was like that when I started down this path 35 years ago. It's projected to be that way for the next 25 years. So it's not an easy thing, but to find someone who has an interest in listening and approaching a holistic vision of and this is one of the things that I like about child psychiatry, because child psychiatry, our orientation to training doctors is a systemic approach. So we don't just think about the kid, we think about the kid when they're at home and when they're with school and when they're with their church family and when they're with their relatives, and who's got the resources to really help with this kid, and who maybe comes in and throws them a curveball and makes it more challenging. And so how do you then deal with that that aunt or uncle or cousin. There's certain people that tend to make it worse. Maybe it's the kid who lives down the block. Maybe it's a certain teacher who, um, children with special needs who are near and dear to my heart, because I felt like I grew up with special needs. Some people are there to help, but some people are there to criticize and call you names and make you feel weird or different. And I think as parents, the more we can kind of help buffer that and help them learn to cope with, because those people don't go away. We get older, but there's always those people who are ready to be helpful and kind. And then there's those people who are ready to, even stick out their foot to trip you, just to maybe laugh if you fall. And I wish we were in a culture that was, trending toward being kind and helpful. But I think in some ways we're moving toward a culture that's a little bit more hostile than it used to be. Starting to feel that way to me. So I think, it's real important for us. I try to remember this as I've walked around the conference here. I do this at the hospital all the time, but as I walk around the conference, I spent 5 years being a janitor for a pediatrician, and the pediatrician wrote me a letter to help me get into medical school. So there have been people getting on the elevator and they've got all their cleaning supplies. And I'll say to them, I don't know whether you clean my room or not, but this is a really nice hotel and you're doing a great job. And it's so much more fun than just standing on the elevator, like looking at the walls, because they respond to that. And I feel like, who takes the time to, so often they feel invisible is what I think. And they're not. They're doing wonderful things for us, and we forget it. And then I also do something silly, just to be fun. So I'll push the red button on the elevator and you know, I have something like this that I pull out and they're like, "What's that?" And that's back to the notion of curiosity, because we do something fun like that and playful, and suddenly we're not strangers in the elevator. And you feel much more connected. And that's when I think we are open to understanding how we might best help each other. So I try to do it all the time because it makes my life a lot more interesting, to feel like I'm connecting with people. Usually it's easy to do in the downtime that slips into everything. And that's what I wish was happening for these kids, is that people would be curious. It's like, oh, I can tell things are, different for you and challenging. Teach me about how did you get here today? If it's the sound of your voice that, when kids feel acknowledged and supported and hey, you see me.
Um, that's that actually might be a good way to end, but we have about time for another couple of questions. Is there
Sure.
anyone have a question? That I know people are typing things in. We have some resources that have been typed into the chat. Little Lighthouse, Creoaks, the Ark of Oklahoma, because people are asking about siblings, help with socializing with these kids, because I know there were some really heartfelt questions about children at school being bullied or teased. And is there something a parent can say to their child to help them? Not, I mean, I think parents with neurotypical kids need to talk to their kids about, not bullying, but is there something these parents can say to their kids to be helpful?
That is a great question. And it's a really difficult situation. And I remember being bullied when I was growing up. The first thing that comes to my mind is that we really do want to say something right away to fix it. We can tell they're hurt by it and they're in distress when they sometimes begin to tell us about it. Interestingly enough, probably the most powerful thing is to listen and ask questions that have to do with supportive recognition, like, oh, that was really difficult. I can see how that hurt your feelings. That was hard. How did you get through it? One of the things I'll sometimes ask kids is, it's a funny kind of question. Like I might say to that kid who was in distress, you got through that. You came home. You told me your story. Did you know you had that much courage? Now, that's an interesting question because whether they have courage or not, I'm kind of saying I can see it, right? And if they didn't feel that they were doing something that was strong, I'm inviting them to be aware of it, right? Did you know you had that much courage? And if they say no, I was like, well, let's think about some of the things you did. Did you hurt yourself? Did you hurt somebody else? Or even if they retaliated, I might say, well, how did you stop yourself? You started hitting him, but some part of you stopped hitting him, and it's always, I don't like to be hit. I bet they were glad that you stopped. How did you stop yourself from hitting him? Because my old parenting paradigm would be scolding the kid for their aggression, as opposed to, I might say I'm kind of sad that, well, I'm really sad they hit you, and I'm kind of sad that you hit them, but you stopped. How did you do that? And so there again, curiosity, my curiosity about them hopefully invites their own curiosity about their behavior. So tell me more about it. What do you wish would happen next time? Who do you want to help you with this? Is there somebody at school you trust? Because there's, the rescuing part of me wants to go in there, and say to the school, I want to meet with the principal and, let's get rid of this kid who's picking on my kid. And, maybe that works. And I'm not saying there's anything wrong with that. That's, advocating for your child. But even there, I think if I were to walk into the principal's office and say, I have this concern, not just for my child, but for this other kid, help me understand what can you guys do? What can I say to my kid? What can we do to help solve this problem? Because I think when we come in and we're harsh and accusatory toward the school, it puts them on the defense, as opposed to, let's sit down and strategize about this problem, because I don't want it to persist, but it doesn't feel as hostile. It feels like I always feel like I can get places quicker if we end up on the same team, as opposed to being adversarial. And
Yeah.
that's true with the interactions with kids, but also all of us around. It's like easy to say, like I might even say, what's going on with this other, I'm concerned for this other kiddo. Is he getting the help he needs? Because he's probably in distress too if he's picking on my kid. Who's checking on him? Is he okay?
Yeah. I think, yeah, so giving them, that's a really good mindset to have in approaching people, I think. There's one last question. I have to say, what advice do you have for knowing if a kid can't or won't? How do we understand their abilities without overcompensating? And
I
that's
read that one.
the last question.
That's such a great question. Um, for some reason, there's a song called "The Little Engine That Could" comes to my mind, because I will tell you, I think we're horrible at predicting what people are capable of. When you look at people with really severe disabilities who have been highly adaptive and overcome them, they'll blow you away what they can do. Um, and so I think but obviously, if you've got a big challenge, it takes a lot of effort to overcome that. Um, and there's lots of examples of that, but I think ultimately we have to ask, the kid, like, is this something you want to change? Is this something you want to so how would I put it? They've got this. So one of the things I like to say to kids that get really angry and they get into trouble with aggression, because we get that a lot in terms of hospitalization. I'll say, hey, I've noticed, like, it sounds like you get mad sometimes, maybe a lot. Do you ever feel like your mad feelings are the boss and they're getting you in trouble? Like it happens before you even know what's happening. You're getting angry and upset and you're doing stuff, and then you get in trouble, and it's your mad feelings that are getting you in trouble. And I bet you 85 to 95% of the kids will, yeah, that's right. And then I'm like, well, what would it be like if you were the boss of your mad feelings? Would you like to learn to do that? Would you like to learn to be the boss of your mad feelings so you don't get in trouble as much? And if I can get a yes there, now I can introduce new ideas, but we're on the same team, we're collaborative, and I'm not. Um, I think kids get a lot of this, whether it's direct or indirect. It's kind of like you're wrong, you're bad, you're the problem, as opposed to, like in this case, we call it externalizing. The mad feelings are the problem, not you. Your mad feelings are what getting you in trouble, and they're not really you. You just have to deal with these mad feelings. So, and sometimes we might even call it the illness. I work a lot with children with bipolar illness, and of course, they rage very easily as well. But even the children I work with autism, they often understand that their mad feelings are getting them in trouble. Um, Often they'll have things they love to do. Autistic kids are wonderful because like I had this one kid. Uh, if you wanted to talk about sharks, he could talk to you about sharks nonstop for 2 months, 24 hours a day. And so, like that was his wheelhouse. So I would like tell me about the different sharks. Which one do you think is the most angry or the most mean? And how do these other sharks keep from being mean? And this was not a kid we were going to have a direct conversation about his issues, but we could talk about sharks. How do you think sharks learn to have friends? Or do sharks have families? Are they nice to some people and maybe angry at other people? And so by working through the metaphor, for him that was safe. If I was going to talk to him directly about his anger, he just shut down. He's hospitalized with it. And this kid actually was on residential. The family was like, we can't even have him live with us at this point. And we talked about sharks for weeks and weeks. But then that conversation was all of the pro-social behavior stuff about, does a shark take a deep breath and count to 10? When they do that, did they blow bubbles? And just make it fun and interesting, and then they can tolerate being in the conversation. Whereas if I go, until you fix this, you're not going home. I mean, can you imagine the burden of just that statement? And how is that kid ever going to want to connect with me if I'm like, I'm here to fix your problem so you can go back to home? You're screwing this up. That's why you're in the hospital. But that is what comes with these kids so often, as opposed to, oh, there's a thing, and if we fix this, your life could be different and better. And teach me how did you learn to do this? And I'm picking the things that are moving the ball in the right direction so that I can build on it and first learn about their skill set when they're at. And then if I've spent a lot of time listening and being interested, then when I throw out that one little added comment like, oh, does your sister know how to do that? Because the sister's the target of their anger. So I'm guessing we're right up against the time. And I will tell you, I've talked to Betty. I would love to do this on a regular basis because I really enjoy that. I thank you all for the opportunity to be here. This means a lot to me, and I so appreciate the invitation.
Hey, you've been great. I loved what you had to say, and I know that you were so helpful to so many parents, and I appreciate you taking the time. And I also